Thank you, Sally. That's great to see the research being done and following up with the innovations coming out of industry, linking the two together. We've got time for a few questions, if there are any. Yes, great. Could you just flick those light switches on for us? That's great, thank you. That's on. That's working. Right, there's a question right at the back there, Barry. Well, no, here, sorry, back wall.
Thank you. This question is for anybody that can answer it. I've learned so much today, but I still haven't got the answer to one question that concerns me. The lesion that I have on my spinal cord, I'm told it has healed. Now I imagine that to be like a damaged skin that's healed. Has it healed and shrunk and will eventually just disappear and heal over like a lesion in the skin, or does it always remain there and will it always be a problem to the nerves?
So I think that's one for you, Daniel.
So this is a very common statement that people get. I assume you have transverse myelitis, is that correct? Okay. So in acute transverse myelitis, we can see on the MRI generally an acute change. There's some swelling, there's some increased, some bright signal. It's usually whitish in the spinal cord, and then when it heals, when the swelling goes away, in many patients we can see for the rest of their life a little bit of a scar. There's a little bit of tissue that's still abnormal. Maybe you see some shrinkage of tissue as evidence of tissue that's being kind of carried away when it was injured. And then there's some patients like you where people like to say, oh, it has healed because we can't see it anymore. I think it's a little bit of a bad use of words when physicians do that.
I think the words were healed nicely.
So when I think what they're trying to tell you is that there's no evidence of an ongoing inflammation still being there. But what you generally left with, I mean, you had inflammation in that spinal cord, which likely damaged some of the wires as they went through. It damaged some of the oligodendrocytes when they went through. Because I assume you still have some residual deficits, do you?
Yes.
Right. So from there you know that this lesion has not completely healed. We may not be able to see it anymore on the MRI, but you still have the lesion, and probably for life. That was a point I was trying to make, I forgot to make earlier. An ADRT program is not being designed that we're going to do for the next couple weeks, or maybe a couple months. This is a program that you want to work with your physiotherapist to build into your life for life. Because even people who go back all the way to pretty much normal as compared, well, so that the layperson doesn't see anymore that you had an injury, they still require a much higher amount of activity to maintain their function long term as compared to their peers. So I think you will always have that scar. You may not see it, but you can feel it. And maybe some people can see it.
Thank you.
Another question, Barry behind you. No, turn around, Dick Whittington. There we go, just on the aisle there.
Question for Dr. Becker. Referring to your graph, which said extra activity leads to extra regeneration, does that apply equally to the sensory nerve function as well as the motor nerve function?
The short answer is yes, it does. It applies. You can. If you look at the spinal cord, as that Kurt pointed out earlier, each single function travels on its own little highway. You have a sensory pathway for pain and temperature, you have a pathway for vibration and light touch, you have pathways for sensation, for kind of proprioception, and you have the pathways for motor. We believe from the research that we have that all these pathways are affected by activity, including bowel and bladder. So the autonomic, the involuntary nervous system is affected as well.
how might you activate the sensory function? I understand how to activate the motor function, like walking or cycling.
Well, the sensory are the easiest ones. Because motor is always tough. You have to find this, as you explained earlier, to kind of find the right muscle connection, to find the right placement for electrode. Sensory is great. Or she gone? No, she's still there. She is the queen of sensory stimulation. So, but for example, to kind of put this down to more simple terms, you can use vibration. This is sensation. You can use
Brushing.
yeah, any kind of brushing. Heat and cold. I mean, these are very simple things that you don't have to do all the time. That you don't have to need a special device for. So.
Thank you.
Another question. This question right at the very back. Right at the very back down this one, Barry. Yeah, that's right.
Hi there. I was just wondering, because I miss out on a lot of physiotherapy, basically because when the appointments come round to me, I'm usually in the throes of what I call a bad day. Where my muscles seize and tense up. I don't have much movement, even though I can move, but it's difficult. It's like walking through treacle, if that's a way to describe it. But I'm just wondering, what are the benefits, if any, that you can get from actually using FES while you're in the throes of what I call a bad day? Or isn't there any?
I think it's probably just the right time to do it. That's when you should be doing it on those days.
You should be doing it when
Yes.
you're feeling at your worst.
Correct. And that's why we're trying to build these programs into your home, because we know you're not always able to go to a center to get your physiotherapy. And also in the home setting, you can kind of plan it into your times when you feel the most energized to do that. But because it's a vicious cycle, so if you have a bad day and you don't do anything, then that day you lose that one of your therapy time. And so presumably you have a little bit less function the next day. So maybe you have another bad day. You kind of go down this little spiral where at some point you don't have enough energy to do anything. And then you actually need professional help.
That is exactly the way that I've been going, because I haven't, I was sedentary for near enough 2 years, either because I was stuck in a wheelchair or just stuck in bed, very sedentary, and to get things moving again in the physical rehabilitation department has been the hardest job, because when I wasn't able to make physiotherapy, there was nothing I could do at home to fit in with my schedule. So it always seemed like I was always having a bad day when those physiotherapy sessions that might be useful to me came up.
I mean, that's a very common trap that you can fall into. And so if I have patients in my clinic, what that happens to, I try to actually get them admitted as an inpatient, so that we can actually do therapy in a hospital setting. I think there was a question.
It's for Dr. Becker again. Going back to the biology. You can have this question if you like. Of the functional recovery that you see with activity. Is this neuronal regeneration? Is it plasticity of existing surviving fibers? Or do you know? Or both?
Difficult question. But in the spinal cord, we have not seen new neurons being born. So we think that the recovery of function from the spinal cord level is because we're repairing some of these wires. We reinstate insulation to it. When we do that, we get the function back. So we think it's a remyelination approach.
Can I make a comment on that?
Yeah.
So does that mean it's neither plasticity nor new neurons? But is that somewhere in between?
Or can we have plasticity and potentially new neurons and remyelination of exposed axons?
Well, the neurons that you have that are surviving, and they can relearn. I mean, that plasticity still goes on, so they have to keep relearning. So you kind of help them relearn new function while you're reestablishing the old connections.
So let me just make an observation that I alluded to but didn't show you this morning. And so we did an FES in patients with progressive MS who had progressed to the point that they were in a wheelchair. And we gave them FES for 6 months in their home. And so I showed you a little bit of the green versus the red, that they functionally got better. The question is, why did they get better? Was there an underlying biology? So these patients were great to give a spinal fluid before and after. So we had a paired analysis of their spinal fluid when they were just on their kind of regular therapy, which was very little, and they were in a wheelchair, and then after the 6-month period. And it was very interesting what we found. So there's a couple things. One, the growth factor environment. In other words, there's a series of growth factors that trigger nerves to function better and form better synapses. And those were very low at the beginning. And those were much higher at the end. So for some reason, triggering skeletal, muscular contraction in this rhythmic way triggered a growth factor environment within the central nervous system, as defined by that spinal fluid, that may have contributed to this recovery. The second thing that was even more surprising was that the inflammation that is characteristic of an autoimmune disease like multiple sclerosis, these bad factors that were very high at the beginning actually were low at the end. So you had at the beginning high inflammation, low growth factors. At the end you had low inflammation, high growth factors. And just one more point, that we don't know the answer in terms of what did those growth factors do. But I'll tell you what I think it is. I don't think it's necessarily new neurons. I don't think it's necessarily new axons, but it's new synapses. So this happens to us all the time, right? So whenever we engage in any activity, any physical therapy, anything, more synapses form onto those nerves that are serving the muscles that you're using. And this happens all the time. This is just part of normal health and maintenance. And if you sit on the couch and have potato chips for 6 months, you will actually lose some of the synapses on the nerves in your brain and spinal cord. And so we do this as a regular way to adapt to loading, right? The more weight we need to lift, the more synapses we have. My suspicion is that that's actually what's happening with this electrical activity. It's not new neurons, but you have more synapses formed onto the neurons in the spinal cord, and those make a more efficient movement. So I think it is biological. I don't think it's just kind of, you're learning to adapt to a static level of dysfunction. I think it is changing the underlying biology within the nervous system.
Great. We have time for one more question if there is one. Yes, gentleman with the blue shirt on, just by the doors.
Hi, Doug. Can I pick up on that and say, Doug, can I pick up on that and just ask whether volitional exercise would have the same outcomes as opposed to electrically stimulated exercise? Or either of you, Doug or Daniel?
What do you mean by volitional exercise?
When I say volitional exercise, there's somebody with an MS that's working a passive active machine without any electrical stimulation involvement.
Oh, so you just do passive stimulation without any...
No, just regular exercise.
Regular exercise without any electrical stimulation.
So, so the regular exercise should always be part of this, but there is a threshold. You can, because we have many people who are in our center who are mostly with MS or even some TM who have recovered to a point where you think there's no point of using an FES bike or to use any kind of electrical stimulation because they're strong enough to do it. But their recovery is generally slower because they're generally not normal yet. But in order to get there, we believe there's still benefit from FES itself. So I generally, in all my patients, I add an FES program to them, which kind of puts me at odds a little bit with outside physical therapy programs because they generally tell me, well, the patient is normal, what do you have? You should go home or she. And there's no point of using any kind of FES. But in our experience, I think you still need, even for lifelong, a bit of an FES program and you do better.
I take that point, but at some high level of function, I mean, I think you can do it on your own. I don't think there's anything that is uniquely magical about FES. I think the idea of activity and that at some level of disability, you cannot achieve the activity necessary to trigger these processes. Because, you know, if you're very stiff and spastic and, you know, you try to get on a bike and, you know, you may be able to do maybe 10 RPMs, you know, very slow. That's probably insufficient. Or if you get in a pool, you're kind of just not able to stand or do the kinds of activities that would trigger that. But if you can do that, and you can really do kind of reciprocating movements at a fairly high level, I think it probably does the same thing. I agree that there's a complement of the FES. At some high level of function, you probably can do it on your own. And then as you kind of have an increasing level of disability, I think you need more and more help to achieve that level of activity that would trigger these processes.
Okay.
You agree?
It's always nice to see a bit of disagreement. Ladies and gentlemen, thank you very much for your patience. I'm sure that you found the last hour as exciting and as interesting as I have. It certainly gives a lot of indication as to what we might be doing for ourselves in order to help us cope with the conditions that we have. Please show your thanks to these two gentlemen as well.